Okay, welcome back. So let's move on to the next item on the agenda, which is on page 107, and that's our approach to 2025-26 planning. Claudia, you're our lead on the planning process. You can assume the board's read your paper, but are there any key points or actions that you'd recommend that we consider?
Thank you very much, Chair. So we run through the planning process every year, and it is always a challenge. I think going into the planning round this year, we were aware that that challenge was only going to increase. There's a number of factors behind that, not least, I think, the sort of overarching financial context for the NHS, which makes living within our means really important, but it is, given that we had a deficit plan for this year, we know that doing that is going to involve some difficult decisions along the way. What we're trying to do in terms of the planning approach this year is make sure that we've got a really strong alignment with the overall strategic approach that we're trying to take as a system. And I think we touched on that earlier in terms of some of the conversation about workforce, around trying to make sure that the choices that we make in managing the financial position don't run counter to what we're trying to achieve from a strategic perspective over the coming years. So we're trying to make sure that we have a very clear link between the operational planning process, the SDP process, and the shared delivery plan, and how that links to our overarching strategy. There were just a couple of things that I wanted to pull out, I think that are important to note. We don't yet have the finalised planning guidance issued by NHS England. We understand that may be due in the next couple of days, but we still await that. So we've had to make some assumptions in terms of shaping our planning efforts so far. You set out in section 5, we've set out those planning assumptions, so it's clear that we expect very little in terms of growth in funding this year. Some of the previously ring-fenced pots of money that have supported particular service developments, known as the system delivery funding, that will be rolled into general allocations, so we think those ring fences will be removed. We know that we're going to require a minimum cost improvement of 5% across our providers, and that is a stretching target. The elective recovery fund, which has funded a lot of the improvement in the reduction in long waiters over the course of this year, will be fixed for the system, and will need to operate within that funding. From an elective perspective, that's where we do have a little bit more certainty in terms of what we're likely to be able to deliver following the issuing of the National Elective Reform Plan a couple of weeks ago, which set out that drive to improve 18 weeks as we move forward, and the focus on advice and guidance through that. We understand urgent emergency care is likely to have a specific improvement target, but we don't yet know what. The dental ring fence and the mental health investment standard we expect to remain in place. We expect there to be a real hard drive around productivity improvement, and as again discussed earlier, tougher targets around agency bank usage in the workforce numbers, and that our deficit support funding is likely to be lower in 24-25. So I think even those bits where we've got a fair idea of what the guidance is likely to say, demonstrate that it's quite a challenging position that we're expected to operate within and develop the plans with our providers. The approach that we've taken so far is to make sure that we are really working hand in glove with all of our providers, and we've run 2 system planning workshops. So the first one of those took place in early December. As part of that, we agreed as a collective that there would be a focus on core UEC, discharge alternative settings, a focus on corporate areas, and a focus on drugs and devices, and that we would look at those across the system. Clearly, there'll be specific areas of focus for individual providers, but those are the areas where we think there is a pan-system opportunity that we need to go after. And then we run a second workshop in mid-January to look at further developing those and driving out what we think the commitments are that we're working to in order to land the plan. So that's really an overview of where we are so far. We've set out in there some of the more detailed areas that we think there are opportunities that we're currently exploring around elective, non-elective productivity in the drug costs and back office. But we await the national guidance over the next couple of days.
Okay. And just to be really clear on that, the national guidance, that when it does come, this is for the financial year that starts on the 1st of April.
That's right.
So in fact, what it's doing is compressing the time available to put the robust plans together, which is why I think it's so good that our system partners have been working with us so closely since December on a number of assumptions. Now, some of those assumptions may change when we get the guidance, but trying to put the best possible plan together is really important. So thank you for that. Okay, colleagues, it really is a status update of the process that's being followed. Obviously, the intent, depending on what the planning guidance finally says, is when the submissions need to be made. But we do have a board meeting at the end of March, which we are assuming we will be using to talk about the the plan submission. But if it has to be done before, we might need to take chairs' actions or organise extraordinary sessions, which we will do. But we'll wait for the final deadlines when we are given the information. Anything else that anybody wants to ask in terms of what Claudia's asked so far? Okay. I think the only other point that I'd probably make is, I think the thing that worries me most, and this is an assumption at this stage, but we are not expecting to be getting any additional funding in this next financial year than we've had this year, or not in any substantive way. There may be some more capital, but in terms of the revenue funding, the 4.3 billion to actually fund our services, we are not expecting to get any more money, and that will be a massive challenge for the system with inflation. So we'll wait for the guidance, but I think we just need to be prepared for the difficult decisions and the changes that we're going to need to make. But Mark, you've got involvement in helping to lead the system through this, along with Hannah and others. Anything else you want to add?
I think that point's really important to emphasise, Stephen. So the national news with regards to Q3 of 24-25 and the national announcement around the £22 billion towards the NHS, I think that has been spent, if that makes sense, with regards to things such as inflation pay awards and so on and so forth that have been described and discussed. So we do expect to be operating in a really challenged financial position if we continue to try and maintain and commission services as we currently do. So therefore we are going to have to make changes and choices in that particular space. Hannah and I are in a regional meeting tomorrow with colleagues from across the South East. So what's really important about this is the support that we have from our colleagues also within NHS England. So this isn't we're not being left to deal with this, if that makes sense. There's conversations happening both regionally and indeed nationally in terms of how we can provide services for our population. Most importantly to say also from my perspective, as I said right at the outset, in line with our Improving Lives Together strategy, yes, this is something that we need to construct for 25-26 in terms of living within our means and providing those services, but this isn't the time for us to start making retrograde steps for delivering ILT. We need to make sure that we're thinking about that in our assessment too. There's a process for the whole system, and then of course there's a process for the organisation of NHS Sussex, and we're working through that with the wider leadership team. In fact, just the week before last, we were in this very room with our wider leadership team asking for ideas and suggestions with regards to taking elements forward, which we'll describe, I think, if that's okay, Chair, both in our board seminar in February and then of course for sign-offs in March.
Yep. Okay, perfect. And obviously we're not doing this in isolation. This is what we're doing from a planning point of view. We're talking about the NHS plan, but local government is also distinctly challenged. And I just wonder whether Vince, Mark, Caroline, you want to add any perspectives of the challenges you've got in local government too that you're dealing with. Vince, do you want to go?
Well, where do we start from? I think we're probably in a similar position in terms of knowing exactly what's coming down the track until we get the decisions made on Devo, which will be the Pan Sussex footprint work between the three local authorities. We should hear that this week. That's what we're expecting, and that will then kick into place a whole set of actions where we'll start to work much more closely with colleagues in health about what that means for the different local authorities on a Pan Sussex level. The local government reorganisation will be further down the track, and that will have further knock-on effects as well. I'm sure colleagues and other authorities might have issues about that.
Okay. But certainly, Mark, from East Sussex County Council point of view, you've been doing engagement events with the financial challenges that your particular council is facing.
Yeah, absolutely. I mean, we had our budget setting cabinet yesterday. It has to be ratified by full council on the 11th. But for the second year running, we've had to dip into our limited reserves. The council as a whole spends £1 billion a year. Our general reserves by the end of this year, because we're overspending, will be down to around 10 million. We had to use reserves to the tune of 14 million to set a balanced budget this year. We are now, next year, going to have to dip into service reserves, which is our waste reserve and insurance reserve, to the tune of about 10 million, again, and that's on top of making about £13 million worth of cuts, most of which will fall within adult social care and health. And there's public consultation undertaken on about 11 of those services, and those will be considered by Cabinet at the end of February 25th. So not a great situation. And I think the real challenge when we come on to the the people plan, and obviously our workforce is made up of independent sector as well as NHS and local government. I'm not aware of any authority in the South East that is able to fully recompense independent sector providers for the additional cost of the national living wage and the national insurance changes.
Okay.
So that's a real impact on our commission services as well as our own.
That's great, thank you. And Caroline, Brighton and Hove is in no better position?
No, Brighton and Hove isn't, but if I could comment from a public health perspective in terms of how we can work together in terms of trying to address some of these challenges, I'm going back to that sort of integrated community teams opportunities where, and this paper talks about virtual wards as well, and I suppose one of the challenges that we've got across the board is how we affect some of these financial challenges that we need to address while still ensuring we've got the backup from acute care to support what's happening out in the community. So that's something we hear a lot about, is that the access to specialist expertise to support what's going on outside. So it's pulling that together, I think, that's going to be a challenge for us all. But I think that's something we've got to work to do, and it's about changing those models of behaviour.
Okay, that's great. Okay, final word, Hannah.
It was just to say I work closely with the local authorities around their position, because of course as you can see, we're all in a similar position, and as Mark said, and we know there are big cost inflationary increases in a lot of our providers, and we use the same providers, so working closely on that. And then in response to Caroline as well, that was the part of the workshop discussions that we've been having in the system. Actually, how can we sort of change things around such that we are doing more sort of preventative, proactive, rather than the acute care. So that will be the outputs of the workshop that we need to work through. And so there will be a big focus for us on productivity and a big focus on the working together on the system changes that came through the workshop. But it is undoubtedly, there is a big financial challenge ahead of us, and so we are going to be able to be looking at the best value for money and how we spend our money effectively. And we are calling those decisions for constrained times. And so as a board, I think we will have to get together and talk about some of that over the next 2 months.
Yeah. Okay, I hope that's helpful context. It's not just an NHS issue, I think, is the point I was trying to make, and thank you to the local authority colleagues for sharing your perspectives too. And I think the only way forward is to strengthen even further in terms of working together and driving our long-term strategic aims, because we know that that's the way, that's the solution. It's just how we fund it in the short term is the question. But that's a question for another day. So as far as the report's concerned, you've had an update. Are we content?
Mm-hmm.
Yeah. Next 2 months are going to be critical. Okay, so thank you. We'll note the report with thanks in terms of the progress that's been made, and really just applaud the way that we've started planning so far in advance without the planning guidance. I think that's a great credit to everyone involved with that. So I'd like to move on to something completely different now, but actually is really coming right back to the core of why the National Health Service exists in the first place, and that's improving health and improving clinical outcomes. And what we'd like to do today is actually have a focus around clinical outcomes for cardiovascular disease. But just before I ask James to make an introduction, we've been joined by two of the colleagues, Andy and Michael. Would you just like to briefly introduce yourselves, and then we'll let James do an introduction to the paper.
Thanks very much, Stephen. Well, my name's Michael Corey. I'm a consultant physician, a specialist in hypertension at University Hospital Sussex, but I'm also an academic at the Brighton Sussex Medical School.
You're very welcome, Michael. Andy?
And I'm Andy Rodson. I'm a GP at Brighton. I'm a Deputy Chief Medical Officer.
Great. Well, thank you for joining us and taking part in this conversation. James,
Yeah.
we've got a very clear question. How are we performing on the clinical outcomes for cardiovascular disease, and how can our integrated community teams help drive improvements?
So thank you, Chair. The first point I want to make is I apologise for the length of the paper. It's quite a chunky subject matter with lots to discuss. In terms of the presentation, we'll try and keep this to a maximum of 10 minutes to give us opportunity for questions. I'll start by setting the context about why this matters. I'll then hand over to Michael, who will go through the risk factors and primary and secondary prevention and the importance of those. We'll then hand over to Andy, who'll do the role of the ICT, and then finally I'll wrap up with a request for the board. So the paper presents and examines cardiovascular disease risk factors and outcomes across Sussex. It highlights the important function and future role of the ICTs and how they can start to address some of the healthcare gaps that we currently identify. It looks at how we can take forward the learning from pilots, strengthen cardiovascular disease services, and promote self-care and lifestyle changes. It will facilitate early detection of modifiable risk factors and, importantly, create opportunities for delivering personalised care. So why does this matter? So cardiovascular diseases are conditions that affect the heart and the circulatory system and include coronary artery disease, atrial fibrillation, other arrhythmias, heart failure, transient ischemic attacks, stroke, and peripheral and arterial vascular disease. The important point is they are largely preventable conditions, and also they account for a significant contribution to our mortality. Across Sussex, we see a high prevalence of cardiovascular disease compared to national peers at 6.99%. And across Sussex, we see variation. So in East Sussex, it increases to 7.95%. In West Sussex, 7.35%. And in Brighton and Hove, a reduced prevalence of 4.4%, which probably reflects the age of the population, because we know that cardiovascular disease is more common in an ageing population, but also associated with those with health inequalities. From a population health outcome perspective, there are two important measures, and they are life expectancy and healthy life expectancy. What we see across Sussex is variation of 6 years for men in life expectancy and 4 years for women. But actually, if we drill this down to ICT footprint, that variation is significantly more stark. And what we also know is that about half of all avoidable deaths are due to cardiovascular disease, cancer and respiratory, with cardiovascular disease being the leading cause of preventable death. So I'm going to now hand over to Michael, who'll go through risk factors and the importance of primary and secondary prevention.
Thank you, James. It's a pleasure to be here, and thanks for inviting me. Some might wonder why someone from acute care is part of this group, but all I would say in response to that is that prevention is everyone's business, and it's one of the pivots of the NHS. So we do have to all ensure that we're part of that link. So that's why I'm here. I'm a specialist in hypertension, and as I will say a bit later, hypertension is the leading preventable cardiovascular risk factor. But back to some other things. When we talk about primary prevention, we're talking about preventing an individual in the UK, in Sussex, from having a cardiovascular disease or related disease. And there are a number of behavioural risk factors that might contribute to increase the risk of cardiovascular disease, being the most significant cause of death and morbidity in England and in Sussex, actually still. So when we talk about primary prevention, there are some behaviours that we can address, target in terms of modifying these risks. Alcohol consumption, smoking, physical activity, unhealthy diet, weight. These are all behavioural changes that can be made in order to prevent or reduce the risk of an individual having a cardiovascular event. So very important. So they are easy wins, and lots of this is about knowing what to do, or knowing that exercise is good for you, and so on and so forth. So they're very easy wins. When we talk about primary prevention, there are also some conditions that are important in order to reduce the risk of cardiovascular disease. The most important is hypertension. I'll refer to that in a minute. Again, atrial fibrillation, high cholesterol, and type 2 diabetes. So again, if we cater to the needs of patients who have these conditions, treat them perhaps better, detect those conditions early, it might lead to improved outcomes in terms of cardiovascular disease. So this is in terms of trying to reduce the risk of a cardiovascular disease in itself. Now, there are some patients who already have cardiovascular disease or related disease, and these are patients who have heart failure, they've had a stroke, they have existing coronary artery disease, and these patients, even though they have a disease that may well have been caused by sort of some risk factors, we can still reduce their risk, and this is secondary prevention. So we can still reduce their risk of having another event, because once you've had one event, one cardiovascular disease event, your risk of having another one is much higher. So it's a kind of two-pronged approach. So there are some behavioural risk factors that we can address, but there are also disease conditions that we can improve in terms of our care to those patients. So speaking about hypertension, very, very briefly, it is the leading preventable cardiovascular risk factor. What we find is that the treatment is perhaps suboptimal in deprived areas, in sort of people who are middle-aged, in men and black and mixed ethnicities. And the most significant thing in Sussex is that there's a huge variation in terms of how hypertension is managed. We're talking about a variation of about 30%. That's huge. So what that means is in some areas we're reasonably good in comparison to national figures, but in other areas they're dragging us behind. So when we talk about addressing inequality, that is a very tractable target. So it's not, I'm not going to dwell on all the doom and gloom, but just to say that hypertension is becoming a bigger issue. And we're talking about 9% of the population not being diagnosed with hypertension, even though they've got it. So whatever we're doing, it's possible to do a bit more to be able to detect hypertension better. We are doing stuff. There is perhaps a lot happening in Sussex. Talk about the NHS health checks. It's happening. It's out there. It's a public health measure. But however, when we talk about the number of people offered health checks, it's dropped. And health check is an opportunity to detect an elevated blood pressure and perhaps diagnose someone with having hypertension. There are NHS commissioned targeted health checks for at-risk groups, people who have got severe mental illness that we know have a very high cardiovascular risk, or people who have learning disability. And we're doing really well in terms of doing an annual review of patients, individuals who have a learning disability, sort of even exceeding national targets. But when it comes to severe mental illness, we're not so good. We're talking about less than 50%, when the target's 75%. So there is a lot that can be done, and there is scope to improve. But a condition such as hypertension is a very tractable target that we can make a very, very significant difference if we look at how we do things. And as I said, it's not just the business of colleagues in primary care, it is the business of colleagues in secondary and tertiary and whatever care. It's actually the business of the general public as well. So I think I'll stop there.
So we'll hand over to Andy now, who will talk about the opportunities that the ICTs present.
Thanks, Mike. I'll be brief and take this as read in many respects. So as Mike has described, so there's quite a difference across Sussex in both prevalence and also outcomes and treatment. And I think that you can see on the page 9 that we have been active in some pilot type schemes to try and improve things. There's examples there of both of the 3 places and the pilot schemes that have been, but these are non-recurrent episodes that have been tried to improve that approach. And Mike's been very clear that the prevention agenda here is key. And you can see that the common themes in all of those 3 schemes, or the 3 places, has been a local population health approach and a wrapped around multidisciplinary approach as regards treating and improving the outcomes for those patients. And I think if you then look at page 14 of the paper, or at least you can see that we've looked at this through the lens of ICTs, and the different elements of ICTs range from prevention, proactive care, scheduled services, and same-day access and emergency care. Now, I think it is fair to say that CVD, population health outcomes, are likely to be improved if we particularly focus on the preventative and proactive elements of it. The scheduled part of it, yes, we can draw some of the scheduled care from hospital out into the community, so there's less distance for people to travel and so forth. But you're pretty much going to be getting your most value regarding preventative and proactive type approach. And also the emergency side of things, essentially if someone's having a stroke, pass them to go to hospital. So there's only so much within that. But prevention and proactive is really important. So that at an ICT level, that hyperlocal type approach regarding case finding, really delving into the populations and recognising the deprivation that exists within some ICTs that Mike's described. So case finding, diagnosing will increase your prevalence. That's what you want to do. You want to increase your prevalence. You want to find the cases, but also the treatment side of it. You need to then be able to treat them properly. And you can see also within the things in the tables there is quite a variation that Mike was clear about, the difference in treatment across different ICTs. You need to focus on the ICTs that really need some help regarding improving those health outcomes and finding those patients and improving their cholesterol treatment, their hypertension type treatment. And that is where you'll start to shift the dial from the prevention and proactive type side of things. So there are, within the paper, there's some described plans to draw that work into an ICT lens and way of working, but it requires a prioritisation, a recognition that this is a priority for us as an ICP, and that hard graft as regards actually making a reality of it.
And that's what we're asking the board to do today, to endorse this as a priority programme for the Chief Medical Officer Directorate. We recognise that through this ambitious programme, we would be reducing avoidable deaths, we would be reducing the morbidity associated with cardiovascular disease outcomes, and improve the population health outcome that we've described in the paper. Within the paper, we've also described a timeline for what we would intend to do through the quarters in 25 and 26. And we're also already starting to think about what metrics we would be monitoring, and the governance process for having oversight of this programme within the newly formed CMO business meeting, but also up into the organisation and up to board, likely through IAG, EXCO, and probably FOC as one of the committees to this.
Just
board.
to translate that, IAG being the Integrated Assurance Group, one of our executive committees, EXCO being our executive committee of senior chief officers based around this table, and FOC is the Finance and Outcomes Committee, our non-executive led board assurance. I've done the translation for you, James.
Thank you. So we'll end there and open
Okay.
up for any questions, but thank you.
Well, thank you for a compelling paper, actually, and it's really good to hear the clinical voice loud and clear. So thank you very much for that. Jane, I think you wanted to start.
Hi, I'm Jane Padmore. I'm the Chief Executive at Sussex Partnership Trust and the mental health partner on the board. To give context to my question, I was really heartened to see the recognition of SMI and learning disability in the paper, and also the recognition from you of the challenge we have in performance of the physical healthcare checks for SMI. I suppose my challenge is that didn't translate to the plan. So when we say mobilised tobacco dependency treatment, it's in University Hospital Sussex and Esht, but not SPFT in patient services. And when we think about things we might want to target, the SMI for physical healthcare might be one that we could target as well within this programme. But I fully support this as a priority, so don't get me wrong, I fully support it. It's just that I'd like to see it strengthened in the actions for mental health.
Yeah.
Thank you.
And SMI being severe
sorry.
mental illness. Okay, that's great. Raghu.
Thank you. Well, very welcome paper. It's very great to see the work you've all been doing. My question is mainly on case finding, and it's more, I suppose, for patients to be known to ICTs or primary care, they have to be known in some form to the health service or associated. And there's always been the difficulty to do case fighting with the population that don't present to any health service, if that makes sense. And I suppose, how are we looking at engaging with that in terms of case finding with the general population? I know there's lots of work public health are doing, but that's where we could get them at the earliest before they're presented to any health service or associated health service.
So that's a challenge for these Reading community teams, fundamentally, isn't it?
I think so, and I think predominantly we know that those, I don't even like the term, but the hard to reach patients, if you like, we struggle with, don't we, finding for within primary care to find those patients sometimes and to diagnose and do the case finding. I do think there's a specific reference to care coordinator type roles, and I think that's where there would need to be really an outreach type thing, that hyperlocal type approach regarding particularly with different communities. For example, if there's some communities that have got Black, Asian people have higher incidence of hypertension, it's more difficult to treat as well. So it's targeting those communities, which again comes down to that ICT type level and the care coordinator approach. Just to Jane's point as well regarding the SMI, I agree, and I think that actually the reality is that looking at these things, we're going to be looking at the comorbidity. It's very different to any approach that we do in care finding and so forth. We're not just going to hive off just the CVD type patients. They're going to have comorbidities, which is described in the paper as well. And I think that SMI side of things needs to be at forefront of that as well. So it's a very reasonable challenge.
I think lots of people want to come and answer the same question, but I think Siobhan was first, so I'll give Siobhan the opportunity just to comment, I think.
Thank you. Yeah, so completely welcome paper. I just want to share from the ICT Delivery Board conversation we had last week around the risk of multiple governance routes to deliver things through ICTs. So what's going to be really important here is that we stick to the existing governance across Sussex, and the governance is that there is community oversight groups or boards at each of our place-based executive partnerships who are overseeing what's happening on the ground. And what happens at the ICT Delivery Board, which is multiple stakeholders across Sussex, is that priorities and the strategic direction are adhered to. So rather than set up a governance route for the delivery of this that might sit only within the CMO directorate, it needs to dock into where we've got multiple stakeholders engaged. And the reason for that is one of the conversations we had last week was the risk of new design groups being too medically and clinically orientated. And we had really strong and effective pushback from local government partners and VCSE partners saying, we are around the table at place and we will deliver change at place through the various partnerships that we already have. So I welcome the approach to hypertension case finding, the prevention, absolutely proactive identification of people. And that also needs to happen in the ICT world as a set of priorities rather than in a different place that will duplicate. We are already case finding frailty patients this winter, so we can extend that to can everybody now case find hypertension. My last point is just performance management as well in a way to drive up standards, because when I look at the variation in prescribing performance around high cholesterol is very stark.
It is.
So there will be both a need to say better for the outcomes of Sussex, people in Sussex equals a performance expectation as well as ICTs. I just didn't want to miss that from the paper.
Yeah, I was going to raise a very similar point. Amy, was there anything else you wanted to add to that? Does that cover what you were going to say?
Just a slight addition, but I think kind of amplifies the point Siobhan's made, but also links to something Michael said earlier, which is to, I think, address what Raghu just mentioned. We also need to bring them to the fact that everyone has personal responsibility for their own health, and actually the best prevention would happen if you are monitoring your kind of vital signs from a very early age. So I think that's where, through the ICT work, we've been really clear about the role of other public services, including education, in all of this, because that's fundamental. So
Okay.
I just wanted to mention
No, that's helpful. So Raghu,
No, so I was just going to say.
yeah. If I can just come back to Siobhan's point, which I think is very valid in terms of the variation in prescribing. We're doing some work before Christmas, looking across our system at some of our major services, and the prescribing of cholesterol-lowering drugs was some of the lowest in the country in Sussex. That doesn't quite fit with our ambition around in cardiovascular prevention. And I can't remember the data, but I have a pretty safe memory that the hypertension prescribing was lower than average as well. But there's also then so there's the overall total is low, and then there's variation within that. So I'm interested, what's the best way from a primary care perspective of how we can start to address that in the first instance, trying to bottom out the variation in prescribing? Andy?
I think it's going to be a multi-pronged approach, focusing on those practices where we can see that the data shows that variability. Within primary care, there's a quality improvement plan, which we're following through at the moment, to look at that and using various tools that we can, education through the webinar, but also a proper engagement with those practices at practice level regarding describing, saying, look, this is the data, what can you do to improve it? There is a little bit of difficulty regarding that the incentives and the targets between QOF and the CVD program don't align exactly. So the targets for cholesterol treatment and so forth within QOF, which is one of the ways that GPs get paid from hitting targets and so forth, don't necessarily align with the targets from the CVD national sort of program side of things. But we need to bridge that gap, and we need to do it through the quality improvement plan to a large extent.
And QOF is Quality Outcomes Framework. But Amy, obviously, as the Chief Officer responsible for primary care and integration, is there anything else that you want to add in terms of the work that you're doing in terms of trying to reduce variation in prescribing?
I was just going to say we have a medicines optimization team that are focused on variation in prescribing, and we have pharmacists that work with practices on the ground, and that's one of the things they will be looking at, and alongside many other markers that we do.
Okay, because that feels like that's an important component to this programme, I think, and so let's be explicit about that, I think, James, just bearing in mind the averages. Can I just go to somewhere else, Raghu, first, if that's all right? Caroline.
Thank you. I've got a couple of things, if that's okay. So the first thing is to pick up on the data issue, and I do think that this is something that the CMO's office can really support the alignment of the data sources and understanding what we're actually talking about. Some of the data in the report I don't recognise, and so it's obviously come from somewhere, but I wonder where it's come from. And I think that's would be a really helpful element so that we can properly understand how we kind of improve those population outcomes and where the gaps are.
So maybe I suggest that you have an offline conversation in terms of the data.
Yeah, no, absolutely.
I'm pretty certain it came from the Sussex Integrated Data Set. So.
Okay, it might have done.
I'm pretty certain it did.
My data is better than presented here. It shows better outcome. Okay. But then the other 2 points are kind of linked, really. So the first one was about the prevention issue, and Michael, you gave a really good description of primary and secondary prevention, and I would want to have a sort of, explore how we understand that within the integrated community teams activity, because there's something for me about case finding, addressing risk factors. But there's something about how we develop a system that enables people to live in a healthy way without getting to those risk factor points. And I think that's really an important understanding in terms of understanding the impact of the wider determinants of health on people's ability to be healthy, because we're talking about individual responsibility here. And I actually don't think it's an easy win. I think people do know they should be eating healthily, not smoking, not drinking, taking more exercise, but we have a system that stops people from doing that. So there's something for me about that broader system understanding, and I think that's where integrated community teams who know their communities inside out can have that reach in, but also support the development of those wider determinants.
Okay, I think that's helpful. Okay, and Mon.
Yeah, I was going to echo some of that, because I think this is exactly cardiovascular disease is exactly where we should be focusing integrated care teams, because this is about your population, where you can walk, where you can get healthy food, where the food banks, all the stuff that goes on. I think that's absolutely right. I agree with you there. I'm just a bit. One of the columns is around obesity. Now, I'm sure we must have higher obesity rates. I mean, this is not good obesity rates, but I'm sure we must have higher obesity rates that are showing here. And I think the data's come from QOF, and I think that's probably where there is a bit of a mismatch. I'm going to ask the question, which is a thorny question, but at the moment we know again where obesity is going, where medications are coming in. I just want to raise this as an issue about whether you're putting it on the agenda, and where we're putting it on the agenda as a integrated care board, about managing obesity using drugs in the future and the costs of that. So I do think it needs to be in here as a factor. So somewhere along the line there will be patients that are absolutely appropriate for those decisions to go onto those drugs, and others there won't be. And I think we do somewhere along the line need to be thinking about that.
Okay, so James, just a perspective on weight management drugs?
Yeah, I mean, it's a really topical issue, isn't it, with all the new treatments that are coming online. But given the financial constraints that we are currently facing, it's how do we square that? So within the paper, we talk about some of the financial constraints and the risks that presents, and actually, are there opportunities that we could tap into, linking in with our pharma industry colleagues to see whether there are opportunities. We know that other systems have adopted that approach with huge success. It's enabled a lot of income to be incorporated to address some of these difficult challenges. But obviously we would need to do that carefully, because we are also aware that other systems haven't achieved. So we're working, with partners.
Okay, so I think we need to think about where weight management drugs fit into the portfolio of options that we've got. I'm just conscious. Oh, sorry, Michael. Do you want to come back in?
Just very brief. So a couple of points. Jane, just to reassure you, severely mentally ill. I think work has already started. I mean, there's a huge recognition that this is a problem area. Those patients are already at a high cardiovascular risk. And I have already been involved. Colleagues have already brought me into trying to empower colleagues to be able to do some of these physical assessments. So that is very much on the cards, which is why I mentioned it today. Something we can't ignore. Just to talk to Raghu's point about involving the general population, I absolutely agree. I think the ICTs, fantastic thing. Cardiovascular disease prevention should be made a way of life, not a project. It's a way of life. So, we talk about hard to reach. I don't like that term either. Underserved communities. Underserved communities, hard to reach individuals. They eat. They go to the shops. They interact with services. They interact with aspects of the community. So if we make cardiovascular disease prevention a way of life, that's the way it's going to be solved. That's the way we're going to reduce the risk. And I do agree that data is power, and our data sources need to be robust. But I think when I read about the ICTs, I went and did a bit more background to it. A fantastic idea. That's essentially mobilizing everyone, the whole community around particular areas of focus or importance.
Right.
I mean, it couldn't be better. That has to be the route.
Okay, thank you, Mike. I must admit, there's two phrases you've said today that have really stuck with me. CV prevention is a way of life, and prevention is everyone's business. So I'm going to steal both of those, if you don't mind. Just very briefly, because I'm keen to move on to the next topic. But James, just on page 133, you quite rightly identify that no additional funding for this programme has been identified, and that strikes me as a major risk. I don't expect us to be able to make a decision on that today, but what's the process to determine the level of investment that we're going to need? And then there'll be a separate conversation of what can we afford.
I'm not sure we've undertaken that robustly. And we probably need to link in with our finance colleagues to understand the quantifiable sum. I think Hannah wants to come in.
Shall I come in? It's always that age-old problem, isn't it, of how do we put money in up front in order to realise the benefit down the line? And it's been a subject of many a finance discussion. But there is a business case there. There is definitely a business case there. And so that's the work that we've just got to do, because of course a lot of the investment will be sort of more in the prevention space, the primary care space, and we'll see the benefits through our provider colleagues. So definitely a case there, but that's what we need to work through with the data and the outcomes, and then be able to measure it such that we can invest in the right areas.
Yeah, thank you, Hannah. I'm not being difficult about this, but I'm going to ask you in a moment, do we endorse the approach? And it's all very well saying, yes, we endorse the approach, but we've still got to go through a process of actually how much we can fund and where and when. And so that is going to be part of the planning process if it's going to be in the 25-26 period. That's just the practicality of where we're at.
Yeah.
Amy, just briefly.
Yeah, just linked to investment. I think we have a responsibility as an organisation to make sure that the investments we already make are reaping the benefits that they do. So I think the paper does highlight variation around areas where we actually do invest in health checks for people with severe mental illness. So I think we have a job to do in making sure that we're upping our performance and supporting our providers to make the maximum benefit of the investment that we already put in. So I think there's already money there.
Yeah.
We need to just improve our overall performance.
But if we do increase our overall prescribing rates for cholesterol lowering drugs and antihypertensives, the reality is the drug budget will go up as a result of that. And so we just need to understand that's the consequence of what we're doing. Mon, I need to move on. Is it vital?
I just want to say community engagement about this though, because actually it's a patient's choice whether they take lipid lowering agents, whether they do any of this, and I don't see very much in here about that. So it's a really important thing that we need to think about in those integrated care.
Okay. So again, something else, James, just to figure into the overall plan is what's the community engagement plan. So that's helpful.
And I think in the ICT planning, there's something about how we use people as assets to push that.
Yeah, as Mark Staten has often said to me, people do have a choice, and even if that's an unwise choice. So I think that is a reality. Okay, so colleagues, we're asked by James and the team to endorse this overall approach. There's still the practicality of what we can afford to do, but as a principle, is the board supportive of this overall approach to cardiovascular disease prevention? I'm seeing a lot of enthusiasm for that, so thank you for that. Thank you, Mike and Andy. I know you need to go, but thank you for your input this morning, so appreciate that very much. And welcome. So we've got two more guests come to speak to us today. So Mark Smith, you're going to introduce the Sussex Health and Care People Plan for us in Indiana's absence today. But Caroline and Lara, would you like to introduce yourselves, please?
Hi, I'm Lara Bell. I'm a GP in Burgess Hill, and I'm here with my hat as the clinical lead for the Sussex Training Hub.
And I'm Caroline Julian. I'm Chief People Officer at Sussex Community Trust.
Excellent. Well, thank you both for joining us and for your contribution in terms of the paper. Mark, obviously, normally Indiana would be presenting this paper, but back to the old job, I think.
Yeah, thank you, Stephen. Yeah, old habits die hard. So back to the CPO element of the role. But it is really important, and it was a privilege to be here 16 months ago when we approved the Sussex Health and Care People Plan, and then subsequently took it to our assembly. And so many people around the table today have contributed not just to the development of the plan, but also its implementation during that period of time. I'm not going to take too much time of that away from Lara and Caroline with regards to the work that we've done to date, and indeed that we plan to do in the future in respect of the plan. There are a couple of points that I just wanted to pull out, though, acknowledging the 5 priority areas. And 2 things really that have really a parallel to the conversation that we've recently just had with regards to what we are doing and how we are as efficient as we can be with our people spend from a temporary staffing perspective, and that was discussed earlier in our agenda this morning. And as colleagues can see in terms of this particular update, the work that we've done in the South East Temporary Staffing Collaborative is now starting to bear fruit. Rahul mentioned this in terms of the agency reductions, but equally the challenge that Hannah and I know is we need to make further inroads in this space, particularly in bank staff. But that award-winning now service, as I can articulate it from the HSJ recent awards process, there's been a huge amount of work from system partners, predominantly in our provider organisations, that has gone into really making sure that we're driving our temporary staffing position down, and so therefore that's huge success. The second element is with regards to education, and the reason why I say parallels with the previous paper is how much time, energy and investment can you place into things such as education for the workforce of tomorrow, as opposed to that of managing the workforce and indeed paying for the workforce of today. And colleagues will know it was a massive part of the people plan about how we could work with higher education, further education partners in making sure that Sussex had a robust position as possible with regards to its future workforce to serve our population and our improving lives together strategy. The report calls out a couple of elements to that. We've got videos and links and all sorts. We're not going to play those today, obviously due to time, and people can watch them in their own time. But there are a couple of elements that I just absolutely want to pull out from an education perspective. So firstly, that we put in place in 2023 with Jane's organisation and Sussex Partnership Trust with regards to the guaranteed employment model with Brighton University, the work that we continue to undertake with the University of Chichester, the Community Diagnostic Centre, and that Queen Victoria are taking forward at the moment is going to be vitally important in Bognor Regis. And indeed, some of the education elements with regards to further education and our T-level students. You know, it's a real, I can just be honest about it now, and I know Indy would have done it in a potentially different way, but it's a huge passion of mine to make sure that our community, our children and young people, which again has been described earlier, have employment opportunities and different routes in order to obtain them in the health and care sector. And the T-level work that we've undertaken has been phenomenal, both across from east to west in terms of some of those videos that we'll show you in terms of students coming forward and then having a career in health and care. But I will pause there and I'll hand over to Lara and to Caroline with regards to where they are in their respective positions.
Okay. So I'm going to talk about the primary care aspect of this. So in the papers you've got the Sussex Primary Care Workforce Plan, which is essentially a roadmap to increasing numbers and retaining Sussex primary care workforce. So that's in line with the long-term workforce plan and local strategies and things. So training new and existing staff and recruiting people into Sussex, and then most importantly retaining them, keeping them there, and also thinking about reforming the way both people work for lots of obvious reasons, but also the way we train them, because this is not going to work unless we change things relatively dramatically. We won't be able to achieve the numbers. But again, my thunder got somewhat stolen about the increase in GP numbers. So we are delighted that they've increased by 11% in the last couple of years, which has very much bucked the national trend. So that's great. The rest of the workforce, the rest of the primary care workforce has also grown, just not quite so spectacularly. So that's also good news. The R's roles, which is the additional roles reimbursement scheme, I knew is going well. We've got about 1,000 of the 18 roles in Sussex, which is definitely over the original target of 754. And then we've got a whole range of initiatives that are aimed at increasing the primary care workforce, and in particular our new to primary care programme, which supports the newly qualified GPs and new to primary care nurses and other clinicians in that sort of really critical first 2 years of massive danger of attrition. Just going back to the training side of things, the education side of things, most PCNs are now approved as clinical learning environments, which obviously helps with quality of training, but also in terms of trying to increase learner placements coming through. And the vast majority of our practices are education environments. So we've got 134 out of the 156 that do support education by taking learners. So that's fantastic, and all credit to them, despite all the constraints that everyone has. So also the big challenge is going to be trying to maintain this momentum, and over the next year and the subsequent years, to maintain this and reach those ever ambitious targets for the increase in the workforce.
Well, thank you, Lara, and I think PCN will be Primary Care Network. I guess the acronym you forgot. But again, I think it shows the benefit of having a professional, robust primary care workforce plan, which is obviously in the appendix we've got today. So thank you for your involvement in that. And Caroline.
Yeah, so in the spirit of looking back and looking forward as part of the update, I think there's a few points to raise. So first of all, the work we've done around our occupational health services, I think, should be noted. We have now across 3 organisations a memorandum of understanding and some shared training. We are sharing triage practices, standard operating procedures, competencies, etc. So a lot of work has gone into this, and I think this is one of those elements that is not just about healthcare providers actually, but there's interest from local authority partners, VCSCs, etc. So this program needs to continue to build on. Mark mentioned education, but I think the work that we need to continue to do to share our workforce, and in particular our education opportunities, placements, our work as anchor organisation to create employment, so wider determinants of health. We know that employment is a key component of that. So reaching into communities to increase employment opportunities needs us to work closely together. So I think more work on that. And then we've talked a lot about ICTs, and Laura and I've been listening to previous items. I think the work that needs to be done around that, around workforce modelling, but also working together, and the organisational development programmes that need to be into that, need to be looking at pragmatic approaches to the work that needs to be done. So a common purpose, whether it's cardiovascular disease or anything else, sharing a common purpose for the population is going to be how we're going to develop those multi-professionals and multi-agencies to work together. So again, the CPO, the Chief People Officer community has a role to play in that. And then just a couple of other priorities. I think job planning is becoming an NHS England priority for medical workforce. And again, we need to do this, especially as the workforce starts to work more across organisations. We need to do that jointly. Equality, diversity and inclusion is not resolved in Sussex. There's quite a lot of work to do still to have an inclusive and diverse workforce that represents our communities, and collaborating around other functions, so other HR functions, is going to be another area of focus, not just to reduce costs, but also to improve efficiencies and experience across all provider organisations.
Great. Well, I think there's lots of examples here of a number of really good initiatives that are all very consistent with the initial plan. So, which I think is fantastic to see. If I just go back to the reason we have a Sussex Health and Care People Plan, it's because the ultimate vision when we set it as part of the Improving Lives Together strategy was one Sussex Health and Care workforce. And I know Mark knows this is coming, but I'm interested in terms of, we've seen a lot of NHS examples in this paper. But I'm interested, Mark, just from the local government perspective, are there other examples that you could also, just to add a little more colour, what's happening in local authorities around the people plan as well?
Yeah, of course, and I can obviously only speak for East Sussex, but I'm sure colleagues in West and Brighton have something similar. So we've got an awful lot of recruitment and retention strategies and approaches for our workforce, retire and rehire. We max out apprenticeships as much as we can. We've got a teaching partnership with the local university for social workers, free training for independent sector providers. And this goes on to what I was saying earlier, that there's 3 main groups of employers in the health and care system. There's the NHS, which is obviously quite a large employer. Local government, I would say, is actually a relatively small employer. And then the independent and voluntary sector providers is a huge employer in terms of frontline care workers. So, you know, the work we do to facilitate that workforce as well is equally important to the delivery of a people plan. So overseas recruitment, we offer free training for care workers. I think the challenge, although there are some examples, we've got a historic example of an integrated support worker that tried to blend the healthcare assistant and care assistant roles fairly successfully, actually. But the real challenge to a single mobile workforce is the difference in pay and conditions. And until we can crack that one, I think there will always be a limit as to how far we can go towards achieving our collective ambition of a single workforce.
Okay. But I think the only reason I raised that is that we were having a planning meeting for the next Sussex Health and Care Assembly. And in July, we're going to be looking at the Sussex Health and Care People Plan. We'll be going back to the Assembly because the Assembly is the body that actually approves the strategy. It's not this board. We're responsible for implementing our part of it. But I think certainly the Assembly has got the overarching responsibility for improving lives together. And so I think there's a real opportunity over the next sort of few months to think about how we can make sure that we're using some of the really good examples we've got in the NHS, some really good examples we've got in local authority, in the voluntary sector space, and how we can bring this together to present a compelling, joined up approach back to the Assembly in July. So that will be the ambition for the reason for raising it. But Rahul.
Thank you, Chair. And obviously this was a report that came to the People and Digital Committee earlier this month. And one of the elements, I think, just picking up on what Mark and you have said as well, Stephen, is optimisation of the apprenticeship levy. Now, we talked about its use within the providers, but also actually other organisations within Sussex. So if there's a point that could potentially go to the Assembly to discuss whether there is an opportunity to look at unused levy across Sussex and actually repurpose that for retraining of staff.
Okay, that's an interesting idea to explore, I think. Okay, Christina.
Yeah, thank you very much, Caroline, for the paper. Very interesting and really good ongoing sort of initiatives in here. I think I'm looking at and I want to avoid an acronym, so I'm going to find the actual word, which is the Advanced Clinical Practitioner Program, the ACP program. I saw that out of the 47 trainees, there were 13 qualifying. I'm just wondering whether, was that the number that was expected? Was that too low a number? And if so, what were the levels of, say, disparities in completion rates, outcome for trainees from different demographics or professional backgrounds, as an example?
So this is in this paper, so I'm not familiar with absolutely every figure in that. Sure. But I think you raised a good point around advanced clinical practice, and it's linked to the other issues that we've got around education and opportunities to train across multiple organizations through placements, for example. So how do we train and equip clinicians who are already working at a high level to have advanced practice in any care setting, and how we develop those skills across multiple organizations? I think there's a lot more work to do. I mean, Mark, I don't know if you agree with me, but there's a lot more work to do in that space to grow that workforce significantly across all organisations.
Okay, I think James wanted to come in.
It's on that point, actually, because one of the things that I was thinking about, given the strategic ambition with integrated care teams, one of the necessities for that is that actually people are going to need to work across organisational boundaries, and actually in acknowledgement of that, are we doing enough at pace to actually push that agenda forward? Because it could be something which slows that programme down.
Okay, interesting. Okay. Sorry, Lara, do you want to respond to that?
I was just interested about the numbers, because I think this is a snapshot in time, so it does take it typically takes sort of 3 years for them to go through it. So I think 13 qualified, but I think most of those are still on the programme.
Okay, good. And Siobhan, you want to come in?
I just had a question, Laura. It's really great to hear the success of retention and growth in primary care more broadly. It takes me to the additional roles reimbursement scheme posts.
Well done.
And there has historically been a little bit of tension around not enough of those roles to go around both provider organisations, primary care. I just wonder what you think the opportunity is to join that world up now. We hear that many people wish to have portfolio careers, and we want to proactively plan for them to spend part of their working week in primary care, ambulance trusts, acute services, mental health community. But we've never quite joined the planning part up. Is there an opportunity, based on what you said, to do that better?
I think absolutely. I think absolutely there is. I think the other slight hitch with the R's roles is because of the nature of them. We actually, again, it's a snapshot in time. We don't know whether people are really staying or whether they're just moving around. So you know, obviously no one wants to rob Peter to pay Paul. So absolutely it needs to be joined up.
Okay. Maybe just give Mark you the last word as acting Chief People Officer. You know, in terms of the next steps with this, we've seen some really good examples of work here. You know, what's your ambition in the coming months and year?
So our ambition ultimately is to continue to deliver the plan, but we're also mindful of that we're halfway through the plan, and the context in which we're operating continues to change, and we need to look at that. But this was a strategic plan in line with improving lives together as our strategy, and as I said earlier, we don't want to make decisions that take retrospective in that space in terms of take us back as opposed to that take us forward. I think from an ACP perspective, just to pick that up as an example, I mean, ask anybody, I think pretty much everybody in this room has been to Polegate recently to go and see the Unscheduled Care Hub, which I did say earlier would be referenced a number of occasions here, but that is exactly that. That is creating the vision around this. When we say we would like to create one workforce for Sussex, that doesn't mean one overall employer for Sussex, that means one workforce working in harmony together to deliver services for our population. The reason why I referenced that room, it's literally a room, but in that room, there are 3 to 4 different organisations all participating in delivering patient care at once, in synchronicity with each other, as opposed to what can often be described potentially in a healthcare setting as with barriers to one another about criteria and so on and so forth that needs to be achieved in order for patients to be assessed in a particular way. So I think that is where we're going to take it. I think the inclusion around local authorities as we move forward to the Assembly in July is going to be really important to learn those lessons across one another. And then, of course, inevitably, we will start to think about what does it look like from 25 onwards, because this isn't like in 2025 we stop educating and everything. We've cracked it. That won't have happened. What is our ambition for 26, 27 and beyond for the health and care people plan?
Okay, great. Well, thank you for just summing that up. So I think as a board, we're asked to take assurance and to note the progress that's been made. Can we safely do that? I think we can. So duly noted. But thank you very much, Caroline and Lara, for joining us today. Thank you to all the other colleagues who are involved in this work as well. It's really important. So thank you very much.